presentation, I would request Dr. Paris to talk on epithelial healing after acute chemical injury.
Morning, everybody, and I thank Uma for making me part of this very interesting group discussion. I will be talking on epithelial healing in chemical burns. I have nil financial disclosures, and as you can see here, like just revising the basics, the epithelial healing, this hypothesis was proposed by Professor Toft and all, the XYZ hypothesis of corneal epithelial healing, and where the corneal epithelial hemostasis and regeneration are maintained by proliferation and anterior migration of basal epithelial cells at x-axis, centripetal migration of cells from the limbus, that is y-axis, and desquamation of superficial cells, that is z-axis, as you can see here very well in the schematic diagrams. The limbal epithelial stem cells situated in the basal layer of the limbus gives rise to transient amplifying cells which migrate towards the anterior layers of the central cornea eventually and forming the terminally differentiated epithelium. This is how the corneal epithelial maintenance is being done. There is another important aspect of this concept of stem cells and limbal stem cell niche. We understand that these limbal stem cells, which are responsible for maintaining the corneal epithelial integrity, are residing into the palisades of Vogt. And as you can see here in clinical picture, the limbal niche is the specialized microenvironment consisting of cells, extracellular matrix, and signaling molecules that are essential for the function of the limbal epithelial cells. So any damage to that or any disturbance to this microenvironment can also lead to dysfunction of the limbal stem cells. So disturbance to limbal niche can result in limbal epithelial stem cell dysfunction. Therefore, limbal stem cell deficiency should also be considered as either limbal niche deficiency. This was a very famous and interesting diagram, schematic diagram proposed by Professor Dua. As you can see here, he just described the concept that how the epithelium is healing, and the epithelium heals on the peripheral part first with, finger-like projections. And if that is, and then the central area of the epithelium is healing. But if that is delayed, and then, the natural defense mechanism of body is the surface has to be epithelialized by anything. So then the conjunctival cells also would come and create a pannus onto the surface of the cornea. So we have to make sure that the corneal epithelium covers this area faster than the conjunctival epithelium. This is the principle for treating all chemical injury patients also. A large fraction of the limbal stem cells can be induced to proliferate in the event of corneal epithelial injury. In addition to transient amplifying cells, the transient amplifying cells are capable of multiple rounds of division. This capability may not be utilized in the maintenance of normal homeostasis, but is significant for response to wound healing. The average cell cycle time for corneal TA cells is 60 hours under normal physiological conditions, and which can be shortened to 24 hours upon simulation, as was highlighted by Uma. Thus, in addition to upregulation of stem cells, increasing the proliferative capacity of transient amplifying cells achieves the following objectives: amplifying each stem cell division and minimizing the need for stem cell proliferation, minimizing the chance of introducing replicative DNA errors into the stem cell population, and providing new cells that are much closer to the terminally differentiated compartment. So, in chemical eye injuries, epithelial healing involves the restoration of the corneal and conjunctival epithelium, often through centripetal migration of conjunctival cells and adherence to the altered corneal stroma. Here, the corneal stroma is not healthy, it is altered, which can be facilitated by treatments like artificial tears, topical antibiotics, steroids, and other supportive surgical procedures wherein we promote epithelialization of the ocular surface. Uh, if we just focus only on the new classification which Professor Dua had proposed, like the previous classifications were inadequate to take care of the explanation of why certain patients do well and why certain group of patients do not do very well post chemical injury. So he proposed a new classification wherein he divided them into 6 groups, and in addition to that, what I have added here is a possible management option to each group based on our epithelial healing issues. So if it is very good and no involvement of 0 clock hours involvement of limbus, then probably these patients would do just well with medical management. If it is grade 2, that is less than 3 clock hours, then they would do either good with medical management, or if you add amniotic membrane graft to that to facilitate epithelial healing, probably you would be reducing corneal scarring in those cases. If it is grade 3, maybe you could, where the damage is, limbal damage is about 3 to 6 clockables, and where 100% medical management and amniotic membrane graft, and maybe possibly you would put in a tarsorrhaphy as well. And for 4, 5, and 6, which is falling into a higher grades, probably you have to resort to medical management in addition to amniotic membrane graft, tenonplasty, and tarsorrhaphy. In some cases, might even require the grade 6 involvement, even sometimes an allogenic slut along with. The other group who proposed a similar kind of classification also emphasized that for acute chemical injury management, one needs to tackle corneal and conjunctival defects, which can be in the form of controlling the inflammation, intraocular pressure, conjunctival and limbal ischemia, and exposure of the eye. So the goals of the management in a chemical injury would be early epithelialization, which can be achieved by control of inflammation, and also once you achieve this, probably you can prevent many complications which would require a surface reconstruction later on. So just look at, I've just brought in a couple of cases to kind of explain how the epithelialization occurs in a chemical injury. This is a case 1 where this patient happened to have accidental fall of cement in his left eye. He complained of watering pain and photophobia, was treated with only topical lubricants and antibiotic drops for 10 days, and he presented like this. If you see, he has on fluorescent stain, you can see a large area of corneal as well as conjunctival involvement. And in 10 days also, the corneal epithelium has not healed completely, just because that possibly the inflammation was not taken care of. So these are the cases who can be treated medically without any surgical intervention, but you have to have the right approach for these cases. So like they would do well with medical management, but sometimes some can use amniotic membrane application based on how they are doing clinically after 1 or 2 days of medical management. This is another example, a 66-year-old female who presented with a history of accidental fall of acid bathroom cleaner in her right eye 2 days back. She was also hypertensive and diabetic. She was on lubricant, antibiotics, and some other ointment. So as you can see here on the cornea, you can see a epithelial defect, but if you look at the surrounding areas, it's important to see all the areas of surface, and then you would know actually how much is the damage. And on eversion of the lead also, you can see that there was significant involvement of the upper tarsal conjunctiva as well. And on fluorescent staining, you can see that there was a large area of corneal involvement plus the involvement of the bulbar surface here. So it is important to control the inflammation to promote epithelialization of both the ocular surfaces, that is conjunctiva as well as the cornea. And as there was not much stromal involvement, most of such cases would respond to medical management. As you can see here, with medical management after few days, and as you can see here, she almost by 4 weeks the surface epithelialized completely, and the eye looks much healthy, and this is by end of 6 weeks. This is another example where a 35-year-old male presented with this kind of a clinical picture. He was one of the pharma company partner. He ended up having accidental splash of sulfuric acid and some lachromatic products in his right eye. He was washing his eyes with water and used ciprofloxacin drops hourly. Also instilled some, homemade remedies, as we always, face those situations. And then, prior to seeing his local ophthalmologist, he did receive topical steroids and everything, but still his presentation was like this. So this was a clinical picture at 1 week with a vision of 6/8 part, blurry vision, pain, watering, and photophobia were the symptoms. And this was the picture of the stain. As the involved surface area was larger, it needed additional procedure to promote the surface epithelialization, and we ended up doing an amniotic membrane graft with a lateral tarsorrhaphy, and he did well eventually. So early intervention can help achieve faster surface stabilization in such cases, and tarso is a very simple tool which can be utilized effectively in such cases to achieve early stabilization of the ocular surface. I think I have just one case, shall I? Or
Continue, Dr.
yeah.
Paras.
This is another case who was a 14-year-old girl presented with accidental splash of household cleaning agent. Right eye was affected more than the left eye. She presented to us after a week of the injury. This is the clinical picture, and you can see that she has quite a significant area of limbal blanching. The cornea is also not looking healthy, and a lot of involvement of the conjunctiva as well. These are the pictures in various gazes, as you can see here, a collage of that. And this is in a similar, with a fluorescent stain, you can see that quite a significant amount of corneal surface was involved and the bulbar conjunctiva was also involved. So obviously she needed surgical intervention in addition to medical management to control the surface inflammation. And here what we did was, we apart from medical management, you need to provide, you need to promote epithelialization. For that, you need to provide either the blood supply to that area. So Tenon advancement was done, an amniotic membrane was done, and a lateral tarsography, and she eventually very well. But you see that the ocular surface looks 2 weeks later after the surgical intervention, and as you can see here, despite all the efforts, sorry, here she is still going to have some areas of limbal stem cell deficiency and pannus formation. So those are the areas where there was a deeper involvement, and probably the involvement of the stem cell niche as well. So the take home points here would be a surface epithelialization post chemical injury will help reduce complications which may cause ocular morbidity. One must tackle inflammation and other confounding factors to promote surface epithelialization in such cases. A clinical assessment and grading of the injury will help a clinician to tailor a stepwise approach to manage such cases, and understanding the role of limbal stem cells in the niche has revolutionized the management of such cases, leading better outcomes. Thank you so much. Thank you for an extra
Thank you,
time.
Dr. Paras, for an excellent presentation. Could you give us some details of the medical management? I see you have not elucidated the drugs that would use. So, in the interest of for our audience, would you tell us what all drugs you would like to use when topically?
Topically, like if you are dealing with any chemical injury, it's important that if you are not suspecting any frank infection, obviously it would not be, then it is important to start with topical steroids. Do not to start topical steroids right away. And the traditional teaching is that you give topical steroids for 10 days and then you discontinue that. But you can decide your dose of topical steroids based on how the patient is responding. And instead of using a very potent topical steroids in the later part, maybe after 1 week or 2 weeks, you could resort to softer steroids so that they can check the inflammation on a lower side, and you can use other methods of promoting epithelialization. But the control of inflammation is a key here.
The other thing that has been mentioned is it's like the initial phase, then the middle, and then the later phase. It is said that when the epithelium is healing, you should not use steroids. But the recent studies show that if there is a high level of ascorbic acid in the aqueous, then the melting does not take place. So it's better to give high doses of ascorbic
Yes.
acid orally and topically, and continue with the steroids to control
Certainly.
inflammation.